Good morning, afternoon to everybody. My name is Roy Weiss. I'm the Chief Medical Officer for the University of Miami for COVID-19, and I'm Chairman of the Department of Medicine at the University of Miami Miller School of Medicine.
Hi, everyone. Dr. Nick Patel. I'm the Chief Digital Officer at Prima Health. Prima Health is the largest healthcare system in South Carolina. We span over 50% of the state. We also have two affiliated medical schools as part of us, and 18 hospitals, about 330 clinics.
Thanks, April. Kevin Riddleberger, I'm the co-founder, chief strategist at Dispatch Health. We're headquartered in Denver, Colorado, but operate now in 31 different MSAs, markets across the country, 18 different states. Delivering high acuity care in individuals' homes.
So Dr. Patel, let's start with you. What would you say the biggest drivers are in equivalence between in-person follow-ups and virtual follow-ups today? And then how do you see that changing or evolving as we're, experiencing more of this digital health world?
Yeah, the great question, April. I've been an internal medicine physician in primary care for 18 years, and I've seen a lot of change occur from moving from paper to the EHR to now this whole new realm. So I think maintaining that continuity of care and that rapport that you build with a patient is extremely important. And what does that mean when it comes to tech? For example, when our nurses are doing a virtual visit, they still do that intake, and they actually set up the technology. They kind of give them an understanding of how the technology is going to be used, that it's going to be secure, and give them that sense of confidence that you're not going to lose anything between what you tell your provider and meeting your needs. And so first is foundationally setting up that fact that most of the patients, especially in internal medicine, are elderly patients. And this is going to be their first foray into using this type of technology. So you want to make it simple to use.
I might add, and everything Dr. Patel said is absolutely true. Rings very clear with me as well. I think in order to really maintain equivalence as best as possible or improvement between the in-person and the virtual visits is the ability to really sort of lay your hands on the patient. It's essential not only for diagnostic abilities, but it's also essential, as Dr. Patel was saying, eye contact, but being able to relate and to empathize with the patient, that they're not just looking at you as somebody who is a picture on a television screen. So the interactive component is, whether it's the vital signs that you get, but what Tyto has really provided is the actual, the stethoscope on the chest, the otoscope in the ear.
Yeah, I mean, the only thing I would add, to it is I think the market forces right now in consumer-driven healthcare are really helping to drive and bridge the gap in terms of equivalence. Consumers, just like in any other industry, are really clamoring for healthcare to be delivered to them in the convenience in their own home, whether that be individuals coming to the home or virtual. Just like they get their groceries or they get a package, same day, the next day, they want to have that ability to turn on their video and talk to their clinician and make sure it's convenient on their time.
And do you see any additional barriers to gaining that adoption, and especially as you think about it for post-discharge or hospital in the home? What can you tell us about that?
I think the long-term barrier right now is a sustainable payment, model for hospital home, services. Yes, there is commercial MA contracts and structure around that, but the CMS waiver is still a waiver. It's not permanent, right now, and there is flaws in the CMS waiver, as it exists, today. And I think it's really continued to work, with legislators on how do we push on this, because there has been considerable, evidence, clinical evidence on the cost effectiveness, the quality, the outcomes around hospital home services.
Dr. Weiss, as you set up your programs, what were the key considerations in ensuring very high quality for your patients and also keeping in mind your provider experience? Does that relate to some of the technical challenges that we've already kind of, glazed over, or was that a little bit more and deeper in thought process?
So, the technical problems are clearly one aspect of it, but what's really crucial and what has been, I think, a major boon to us was to have an appropriate team of individuals involved. And by team, I mean really starting at the level of education, which is key to have trainers on hand to support both providers and the patients.
Dr. Patel, back to you. What do you think are the next frontiers for post-op and hospital at home? Are there new technologies that you're thinking through or other adoption enablers that you'd like to just kind of share with us a little bit today? We don't want all your deepest, darkest secrets. Obviously, we have to keep some of those for yourself, but if you could just enlighten us, that'd be appreciated.
That. But in regards to your question and what does the next frontier look like, I think you have to start thinking about more of a centralized model to support versus a decentralized model by sub-service lines. And you have to change the culture to enable a larger virtual care team managing your patients outside of your office. The virtual transitional care team will have to work hand in hand with your primary care provider or subspecialist to manage those daily activities. You also have to have tech that's self-sustainable with that can be used without Wi-Fi at the house. About all these where the data's coming in, and look at a virtual care team to really help be that quarterback, not to replace your primary care provider or your subspecialist, but to augment that care for what happens in between a lot of those visits. Hence, you'll get to your quality and you'll get better outcomes if you do it that way.
Is that how you look to risk stratify or kind of triage how your team is dispatched out to the home and then what needs to go back to the emergency room, or have you thought about that differently?
Absolutely. It's 100% data driven. So we know we have all the different chronic diseases. We know what the cost is for chronic CKD or hypertension, CHF, diabetes. We know where our major hospitalizations can be avoided. So avoiding not only that proactively keeping people healthy, but preventing that 30-day, 60-day readmission.
Yeah, no, I would just double of the digital front door moving forward on if you have different data streams coming in, whether it be through RPM or other back-end EMR data, to understand based on that patient's underlying conditions, based on their availability of social resources in the home, and what actually clinical services are needed for that individual. And so it really gets into the importance of aligning risk stratification and understanding clinical acuity, but being able to map it to the right level of service.
Gentlemen, thank you so much for your insights today. We really appreciate having you. To TytoCare, thank you for having me.